Good evening and welcome to our webinar on men's sexual health with Dr. Kian Asanad. Dr. Asanad is Assistant Professor of Urology at Keck Medicine of USC and Director of the USC Fertility and Men's Sexual Health Center. He specializes in male fertility and men's sexual health. Dr. Asanad, the floor is yours.
Good evening. Thank you all for joining me this evening. Hope everybody's doing well. I'm excited to get started. Just going to wait 30 more seconds to let the rest of the participants join in, and we'll get started. Excellent. Just if 1 minute past six o'clock, we'll go ahead and get started. Well, my name is Kian Asanad. It's a pleasure to be with you all this evening. I'm located here in Santa Clarita, where our clinic is located. This is the contact information and address if you're looking to seek out a consultation or want to chat after this session. A little bit about myself. I obtained my medical degree from UCLA. I completed my urology residency at USC, and I completed my fellowship at Northwestern University in Chicago, where I specialize in male fertility, men's sexual health, and prosthetics. These are the objectives of tonight's discussion. We're going to talk about low testosterone. We'll talk about erectile dysfunction. We'll talk about Peyronie's disease or penile curvature. We'll talk about ejaculatory dysfunction as well as male stress urinary incontinence. And for each of these different topics, I'll go into what it is, how we identify it, what's the evaluation entail, as well as the treatment options. We'll first get started on testosterone. So as we know, testosterone is the predominant hormone or androgen in males, and it's involved in many different processes throughout men and throughout the human body. It's involved in sperm production. It plays a key role in sexual health in terms of sexual desire and libido, erectile function and dysfunction. It plays a role in physical and mental health, muscle health, bone health, energy levels, cognitive function. It can influence your mood, motivation, as well as plays a key role in fat distribution and muscle mass development. So you can see that if the testosterone levels are low, what are some of the signs and symptoms of low testosterone or hypogonadism? Some of the physical signs and symptoms can include low energy, excessive fatigue, reduced hair growth, reduced lean body mass, increased adiposity or fat mass. Some of the cognitive signs and symptoms can include a depressed mood, feeling like the brain is a little foggy, not thinking very clearly, poor concentration, irritability, hot flashes, as well as the sexual side effects, which can include reduced libido or sex drive, as well as erectile dysfunction. We define low testosterone as a combination of these signs and symptoms, as well as a total testosterone level less than 300. It needs to be an accurate level. So we do the blood draw between 8 to 10 a.m. when testosterone levels peak, and we want to see what your peak testosterone level is. And we recommend, and the standard of care is 2 confirmatory levels of low testosterone to diagnose low testosterone in addition with the signs and symptoms. And why is that the case? Because there's a lot of variability within an individual testing their testosterone because of the diurnal variation in testosterone production. The circadian rhythm can influence your testosterone levels as well as any sort of acute illness. So it really requires two testosterone levels less than 300 to confirm a diagnosis of low testosterone as well as these signs and symptoms. How common is it? Well, it's relatively common. Testosterone levels have shown to decline about 1% or 1.4% every year after the age of 30. In terms of incidence, it affects 20% of men over the age of 60, 30% of men over the age of 70, and 50% in those over the age of 80 years old. But what about the impact of other health problems? A few studies have looked at if as men get older, is it really an impact of age? As you get older, your testosterone decreases, or is it that men are getting older and they're developing other medical problems such as high blood pressure, diabetes, high cholesterol, and those are the things that influence testosterone production and result in low testosterone. And so they've done a few studies and found that in men as they get older without any other comorbidities or other medical problems, they're actually less likely to develop androgen deficiency or low testosterone and can typically maintain normal testosterone levels even at ages 60, 70, and 80. And so the take-home message is that low testosterone may be a marker of poor health and other medical problems. And so when we evaluate men with low testosterone, we typically also evaluate things like an A1C to check for underlying diabetes or blood pressure evaluation or lipid panel and those sorts of things. So that's really a take-home point. It's not necessarily that as you get older, your testosterone goes down. It's really the guys that get older but also develop other medical problems that plays a big role in hypogonadism. So how do we evaluate it? So we talked about 2 blood tests between 8 to 10 a.m. and there's a few other hormones that I like to check that I recommend. So there's 2 hormones secreted from the brain called LH, luteinizing hormone, and FSH, follicle stimulating hormone. And we want to make sure, is the LH from the brain low? Is that why the testicles are not producing testosterone? FSH is a hormone that identifies sperm production. So if men are evaluating their fertility, we'll check an FSH. But for older men, if that's not an issue, we don't necessarily check that. Prolactin is another hormone secreted by the pituitary gland. We're screening for things like pituitary adenomas that can secrete prolactin. And if the prolactin level is excessively high, it can illustrate an underlying microadenoma of the brain, and that can turn off the testosterone production pathway. We also check a PSA test for prostate cancer screening in men over the age of 40. We need to make sure that there's no prostate cancer on board if we're treating low testosterone, as well as a baseline blood count to check hematocrit levels to see if those are elevated at baseline as well. What are the different treatment options? Well, there's many. Testosterone comes in many different formulations. There's topical creams and gels that you apply daily called androgel or not a brand label. There's injections these are the 2 most common injections that you inject in the buttock or in the thigh muscle every week or once every 2 weeks. There are pellets, which are an office procedure that takes about 10 to 15 minutes. We numb up the buttock area. We place these pellets that are long acting and they dissolve over the next 3 to 4 months. It kind of takes your mind off things. Don't have to think about getting testosterone daily, but it does require an office visit every 3 to 4 months for a small procedure. There's some new oral formulations of testosterone that are now safe and don't cause liver problems like some of the older agents did, as well as an intranasal gel. I would say these are a little less common. The most common are the injections and the gels. But it's really important to note that exogenous testosterone, if I gave you testosterone, will make you infertile and it'll cause low sperm counts or no sperm to be in the ejaculate. So it's really important when I speak with men who are being evaluated for low testosterone, always need to check in and see is fertility still important to them? And if it is, I do not treat men with low testosterone. With testosterone, we use alternative agents that can actually help improve the body's natural testosterone production. Medicines called Clomid, HCG and anastrozole could be used for those purposes. While you're on treatment, I'll see you back in a month. We'll repeat the testosterone level at that time and see how you're feeling. I want to see an improvement of your symptoms in addition to an improvement in the blood test. If the blood test is normalized and you're still not feeling great, then there's room to increase. I'm happy to do that. We can definitely do that. Once we get you on a good dose and a good level, I'll typically see you back every 6 months with repeat blood work to keep an eye on the blood counts, testosterone levels, as well as PSA tests. Some of the common side effects include you can develop acne or oily skin, fluid retention, so swelling in the arms and ankles. It can result in breast enlargement, especially if men are overweight. Testosterone could be converted to estradiol. That normally happens, but if there's a lot of fat tissue, that estrogen levels could go really high and cause breast enlargement. We can continue to manage that and optimize that. It can cause red blood cell count to increase or polycythemia. It's more common in the injection standpoint. We really want to monitor the blood counts. If the polycythemia develops or the blood count is over a critical level, that can lead to increased risk of blood clots in the legs, blood clots in the lungs, heart attack, and stroke. If the levels are too high, it can cause irritability and mood swings. In terms of benefits of treatment, if you have low testosterone, you have some of these symptoms, the studies have shown that replacing your testosterone and optimizing it really has a benefit for sexual dysfunction. So improves erectile function, especially when combined with an oral medicine, which we'll get into, such as Viagra or Cialis. It improves sex drive and libido. It improves bone density, lean body mass, improves mood. The data regarding how much it helps in terms of cognitive function, mental strength, energy, fatigue, and the lipid profiles is not as strong as some of the data regarding sexual dysfunction in men on testosterone. Moving on to erectile dysfunction. So erectile dysfunction is defined as the persistent inability to achieve or maintain an erection that is firm enough to perform sexual intercourse and is satisfactory. ED is very common. It affects half of men over the age of 40 have some degree of erectile dysfunction. 40% of men over 40, 50% of men over 50, and 60% of men over 60 will have some sort of erectile dysfunction. And I think when we think about erectile dysfunction, I like to take a step back and let's talk about what is a normal physiologic process of erections. What is the normal erectile process? So when a man is aroused, there is blood flow that goes into the penis where the artery or the blood flow to the penis dilates, it stretches out and improves blood flow. The spongy tissue in the penis, known as the corporal bodies, those will expand and those will compress veins in the penis from draining the blood out. That results in a hard erection that you're able to maintain. The other sides of the erectile process includes the nerves around the penis need to be normal. The hormonal component, such as testosterone, needs to be normal, as well as a psychological, mental component need to be there. If everything in the penis from a blood flow standpoint and the nerve standpoint is working well, but the mind is not right, there's a lot of anxiety, depression, you're going to have erectile dysfunction. So it's really a combination of blood flow in the penis, maintaining that blood flow. The nerves around the penis need to be working well. The hormonal environment needs to be optimized, as well as the mental component. So what are some of the causes of erectile dysfunction? As you get older, you can have ED, smoking, diabetes, high blood pressure, high cholesterol or dyslipidemia, depression, obesity, prostate cancer treatment, neurological illness such as spinal cord injury or MS or multiple sclerosis. All these different reasons can play a role in erectile dysfunction, whether it's vasculogenic, meaning a blood flow issue, is it psychogenic, is it a mental issue or a confidence-based erectile dysfunction I like to think of, is it a neurogenic cause of ED, and it could be a combination of these. I want to take a step and think about how this links to heart disease. So as you can see, a lot of these things such as smoking, diabetes, high blood pressure are also risk factors for heart problems. And so that's really important because we know that erectile dysfunction is a risk factor for future heart-related events. It's directly related to your heart and heart disease. And so why is that the case? Because the blood flow in terms of the arteries to the penis are much smaller than the blood flow to the heart. So typically, sometimes erectile dysfunction can be the first sign and symptom of underlying heart disease. And so when I see men for ED and they haven't seen a doctor in many years, I'll order things like a hemoglobin A1C to rule out underlying high blood sugar, a lipid panel, refer them to their at least at minimum to their primary care doctor or even a cardiologist if there's concern for underlying heart issues. I like to say what's good for your heart is good for your penis. And that's really true, right? Things like eating well, exercising, physical activity, losing weight, stopping smoking, limiting alcohol, reducing stress, all of those things are great for your heart, and they're also great for your penis because they optimize blood flow in both respects. How about diabetes? We know that blood vessels and the nerves resulting for erections around the penis can be damaged by elevated blood sugars. And we know that men with diabetes and ED may be less responsive to some of the oral treatments for ED. There's a study of nearly 20,000 men with ED, and men with diabetes were almost 2 times more likely to need other treatments outside of oral medicines to get a good, satisfactory erection for their sexual quality of life. So let's go into some of the treatments. So we talked about some of the lifestyle changes. Some of the oral medicines we'll get into, such as Viagra or Cialis. There are treatment options such as a vacuum erection device or a VED. There are penile injections where you inject the penis with a medicine to induce an erection. And there's surgery, things called a penile prosthesis or a penile implant. So let's go into some of the medicines. These are a class of medicines called PDE5 inhibitors or phosphodiesterase type 5 inhibitors. They break down an enzyme that typically gets rid of an erection. So they break it down so you're less likely to get rid of it and improves blood flow into the penis. So these are prescriptions. They do require stimulation and arousal to be effective. You can't take these medicines and just lay down on the couch and have no sort of stimulation and arousal and get a strong erection. The most common medicines include Cialis, which is generic for tadalafil, sildenafil, which is generic for Viagra, which are the 2 most common, I would say. Vardenafil, which is the brand name is Levitra, all have the same efficacy and they're used a little bit differently. Some of the side effects can include a headache, facial flushing, it can cause heartburn or upset stomach. It's really important to note that if you take an alpha blocker, such as a medicine for BPH or enlarged prostate, typically want to separate that for a few hours, at least 4 hours from taking a Viagra or Cialis medicine, because the combination of 2 sometimes can lower your blood pressure, and it's contraindicated for men taking nitrates. So if you have any chest pain and require sublingual nitrates for relieving that pain, you cannot take a Viagra Cialis medicine that can fatally reduce your blood pressure and be very devastating. So it is not recommended for those patients. I want to compare Cialis and Viagra. I see this a lot in the office, and I think they're both excellent options, and it really just depends on your lifestyle, right? So Cialis is a medicine that has a really long half-life. It's in your system for 24 to 36 hours. It can be taken with food. Both of them need to be taken 2 hours typically before intimacy, but Cialis is not affected by food intake. It can be given at a low dose daily, given that long half-life, which I think a lot of guys and couples really enjoy because it gives them a lot of spontaneity. And some of the more specific side effects with Cialis, it can cause leg cramping, which is what you don't see in Viagra. And so the daily dose works well. It gives couples a lot of spontaneity, and a lot of guys really like that. On the other side is Viagra or sildenafil. Needs to be taken with an empty stomach. If it's taken with food, it can be less effective. It typically lasts in your system only 6 to 8 hours. It does have a side effect of causing a color vision change or a bluish greenish tint to your vision for some men because it cross reacts with a receptor in your eye. I think of it as Viagra is a little bit more of a rush because it's quicker on, fast off. Cialis is a little bit more gentle. You can take Cialis on a Friday and it'll last in your system till Sunday, essentially. Vacuum erection devices. So these are hollow plastic tubes. They're placed over the penis. They can be battery powered or mechanical powered. It induces a vacuum and pulls blood into the penis. Sometimes you can apply a constrictive ring or an elastic band at the base of the penis to help maintain the erection. I would say this is one of the less common treatment options for ED. It's a little bit more clunky. It's a little bit more cumbersome. It causes sometimes a hard, cold penis that with some penile numbness. There could be pain inside the penis as well. So guys are not super happy with it. I think in my practice, it really works well for men post prostatectomy, meaning if you had a prostate cancer surgery. The VED works well to exercise and stretch the penis, and it's been shown if you do that for 10 minutes a day for 6 months, you can help maintain length of the penis and even gain a centimeter or two. So that's really how it's used in my practice, but it could be used for a treatment for ED as well. Penile injections, this is a medicine. It's given in a very small needle, such as an insulin needle used for diabetes. It's injected directly into the penis 15 minutes before intimacy. How this works, if the oral medicines typically don't work, we can go to one of these other options, such as injection, such as the VED and surgery, which we'll get into. I'll see you in the office. I'll teach you how to inject, and I'll give you an injection in the office so we can try to find a dose that works well and works well for you. Most common side effects can cause pain in the penis. Things that we're worried about is causing a prolonged erection for 3 to 4 hours. So if this medicine is not used properly or is abused or is combined with other things that shouldn't be combined with, it can lead to an erection for over 3 to 4 hours, which is called priapism, which is a medical emergency and requires going to the emergency room for immediate treatment. Over time can cause scar tissue in the penis. Most common reasons to stop are due to poor response, really lack of spontaneity in couples that I see. I think for the couple who is maybe intimate on the weekend or once every 2 weeks and have no problem kind of going in and inject themselves prior to intimacy, I think it could work really well, as well as associated costs. It comes from a specialty pharmacy. You can't get this stuff at CVS, Walgreens, that sort of thing. The last treatment option is a penile prosthesis. This is a medical device that's surgically placed to treat erectile dysfunction. The device is completely contained inside the body. It really is the gold standard for severe cases of ED, as well as any case of ED that's not responsive to oral therapy. There's really no pathway that you have to go through to get to a penile implant. I think some guys don't want to inject and want to have surgery. Some guys will do everything in their power to not have surgery. I don't think there's anything wrong with that. I think it just depends on your lifestyle. But it's been shown to really allow for spontaneity. You can keep the erection as long as you like, as often as you like. It's 100% reliable. And it's fully rigid when it's inflated, and it gives a natural flaccid appearance when it's not. You can see here, these are some of the penile implants on the market. These are the most common devices. These are inflatable, and there are 3 pieces. There is a pump that sits in the scrotum between the testicles. There's 2 cylinders on each side of the penis, and they're customized to your size and connected to a balloon or a reservoir that contains the fluid, all contained on the inside of the body, typically through a single 3-centimeter incision or a minimally invasive approach, which is what I like to do. The procedure takes about an hour. It's commonly outpatient. You could stay overnight in the hospital if you liked. Typically, in terms of recovery, requires oral pain pills for a couple of days to about a week after the surgery. Most men in my practice are usually using the device after 3 to 4 weeks, and a couple of days of light activity before returning to full activity. And you can't use the device again for 3 to 4 weeks. Some of the risks, this is a surgery nonetheless, right? Any surgery has risks. We worried about a risk of infection, thankfully, which is really rare, is about 1 to 2%, especially even lower amongst prosthetic surgeons who do a lot of this kind of work like myself. Mechanical failure, 90% of these are actually working really well at 10 years. Many of these devices are working over 15 years, but it's not uncommon, and 10 to 15% of guys after a decade may need a new implant or a new part of an implant if there's some wear and tear. It can cause unintended inflation of the device, less common with some of the newer devices, as well as ongoing pain and soreness. I think from a patient satisfaction standpoint, when the studies compare the oral medicine, injections, a vacuum device, a penile implant, the penile implant always has the highest satisfaction scores, about 95% satisfaction with intercourse, as well as their partners are very satisfied with intimacy, and 97% would recommend it to others. This comes up a lot, which is why I bring it in terms of cost and coverage. It's typically covered by insurance and Medicare. It's a medical device to treat erectile dysfunction. This is not a cosmetic device. This is not to increase the length of your penis. It is not a cash only pay procedure. It's typically covered by insurance, and we can work with you to find that out. I encourage this website. It's called edcure.com or .org. I think they provide a lot of great videos from a patient testimonial standpoint, to see the patient's journeys with ED and the different treatment options and their experience with an implant. So I encourage you to take a look at that. I think patients that I refer to looking at that have a lot of their questions also answered. Next, I want to go into Peyronie's disease or penile curvature. Peyronie's disease is a disorder where scar tissue or plaque builds up in the penis. It can cause a penile deformity. It can cause commonly a curvature of the penis, and the penis can look bent either upwards, downwards, left, right, or a combination of those. Peyronie's disease is not cancer. It's a benign finding. It's not a tumor. It's scar tissue in the penis. It's typically either due to some sort of trauma that occurred during intercourse or repetitive microtrauma. Most guys don't remember an episode of trauma, but we think there's been repetitive microtrauma causing scarring over many years. In the acute phase or the active phase, there could be pain and soreness in the penis, which can last typically about 6 to 12 months. And that's when the plaque is forming, and the direction and the deformity are forming. Once that settles into the chronic phase, that can take 6 to 12 months. 50% of guys, the curvature can get a little worse. About 40% of guys will stay the same, and about 10 to 15% of guys will see an improvement spontaneously once they're in the chronic phase. That's when the plaque stabilizes. There's typically no further pain with erections or soreness. Treatment in the active phase is really focused on pain management and anti-inflammatories such as NSAIDs. We really don't want to do anything too invasive while the plaque is forming, because any sort of invasive treatments can cause recurrence down the road, and that's not a good thing. So when we enter the chronic phase, treatment is focused on straightening the penis only if that's associated with dysfunction, like the penis is so curved it's very difficult to penetrate. It causes pain to your partner with penetration, or causes discomfort to you during penetration. Some of the treatment options, typically oral medicines, are not really effective. There's not really any great medicine that I could give you orally that you could take that will straighten the penis. They've studied that, and there's really nothing that's come to the market. Penile injections, there's a medicine called Xiaflex, which we'll get into, that came out in 2009, that we can inject in the office to help break in and soften the plaque. There are surgeries where we straighten the penis and remove the plaque sometimes, as well as penile implants that could be used to straighten the penis, as especially useful if there's concomitant erectile dysfunction or ED. So penile plaque injections, this is a medicine called Xiaflex. Again, it's a series of in-office injections. It's a two-part injection. So one cycle is 2 injections, typically spaced a couple days to a week apart. The whole cycle of treatment may require 4 total cycles or 8 total injections, spanning in about 5 to 6 months. So you come into the office, I give you an injection if this is the case. You come back a few days later, we do the second part of the injection. Then you go home for 6 to 8 weeks, and you'll stretch and manually model the penis. You'll come back 2 months later, we'll do another series of injections. Clock resets another 2 months, and we can do that up to 4 times or 8 total injections. Some of the local side effects, pain in the penis, bruising, swelling, that'll almost always happen with each injection. You have to abstain from sexual activity for 2 weeks after each injection, and typically can result in about a 30% improvement in curvature, about 15 degrees. So it's really meant for some of the more mild cases of penile curvature where surgery may not be recommended or patients don't want surgery on the penis. Xiaflex could be very helpful in that setting. There's surgery to straighten the penis. The penis is called a penile plication. It's an outpatient procedure, takes 45 minutes. It's kind of like an adult circumcision with some extra stitches inside the penis to straighten it. I place the sutures or the stitches on the opposite side of the curvature. It results in 100% straight penis 10 out of 10 times. The issue with that is the sutures could be palpable. You could feel them. They don't necessarily cause bother. It's typically oral pain pills for a few days. You can't be sexually active for about a month after the procedure. And when we do the plication, we do a folding over of the corporal bodies on the other side. So that can result in penile length loss. It's really, really negligible. I don't really see it being an issue for most men, but it's a surgery nonetheless. And I think for some men who don't want to spend 6 months with injections, I think plication is an excellent option. Just depends on your circumstance. The last is surgery called plaque excision and grafting. This is really for more severe cases of curvature. These are deformities over 60 degrees. They can have an hourglass shape or other deformity. It's a 3 to 4 hour surgery. It's definitely very involved. It's only reserved for very severe cases where we remove the plaque and we place a graft there to close that space. The main risk of this can cause ED. 20 to 30% of guys will have some sort of erectile dysfunction. So you really need to have excellent quality erections prior to this surgery for you to be a good candidate. If you have bad ED or moderate ED, if we did this surgery, we could straighten the penis, but then the erections wouldn't be great. So we didn't really do much of a service to you. So it's really not recommended for many men. And then it can result in transient numbness of the penis because we have to elevate the nerves of the penis so we can access the plaque. Let's move on to ejaculatory dysfunction. So this can be separated into a few things, right? So there's retrograde ejaculation where the ejaculate goes in the reverse direction. There's premature or rapid ejaculation where men ejaculate too quickly for it to be satisfactory. There's the opposite problem called delayed ejaculation where men can be sexually active for a very long time and be very difficult to reach climax and ejaculation, or completely anejaculatory. So retrograde ejaculation is commonly seen in men with diabetes or some sort of neurologic disease. So what happens is in the normal physiologic process, when you ejaculate, the neck of the bladder closes and allows the ejaculate to be expelled through the tip of the penis. Men with diabetes or neurologic injury, the bladder neck is less responsive to some of those nerves, and so the bladder neck doesn't close as well, and so it remains open. And so the ejaculate can travel in the reverse direction into the bladder and mix with the urine. It's nothing dangerous. It doesn't necessarily cause problems or bother. It's something that's just happening. It can play an issue if you're trying to achieve a pregnancy and there's no sperm in the ejaculate and there's no ejaculate out of the tip of the penis, right? There's things that we can do for that. And it typically presents with low volume and the semen's expelled after in the urine. We can diagnose this with testing where you do a semen test and then you do a urine test and we check for sperm in the ejaculate as well as in the urine. And we can treat this with some medicines, although it's not the most successful, about 30 to 40%. Premature or rapid ejaculation. This refers to either a lifelong or an acquired poor ejaculatory control with associated bother. It's very common. 1 in 3 men between ages of 18 to 59 have PE or premature ejaculation. And this is defined as an intravaginal ejaculatory latency time, which means the time when you're penetrated inside the vagina for less than 1 to 2 minutes. The average time for men to ejaculate is globally is about 7 minutes. If erectile dysfunction is also present, treating the ED can typically improve premature ejaculation. So we always treat the ED as a first step. But some of the treatment options for premature ejaculation, there's some lifestyle things you can try, such as using condoms, start and stops technique, squeezing the glands, trying different positions. There are topical numbing sprays, which are otherwise first line, called Promescent. You can get these over the counter at Target, things like that, which is a numbing spray to help decrease sensitivity of the penis. And then we can sometimes use low-dose antidepressants. Not that you have depression, but a side effect of antidepressants cause delayed ejaculation. So we're using that benefit for patients with premature ejaculation. Delayed ejaculation refers to a lifelong or acquired bothersome inability to achieve ejaculation or excessive latency of ejaculation despite adequate sexual stimulation and the desire to ejaculate. We typically do a detailed review of medications. Commonly, antidepressants can cause delayed ejaculation. It may be associated with underlying low testosterone. And so for these men who suffer from delayed ejaculation, we'll check a testosterone level. Sometimes if we optimize the testosterone, that can help improve the ejaculatory latency time. Really, referral to a sexual health therapist can be helpful, as well as there's vibrators for men on the market that can help for couples during intimacy. Anejaculation refers to a lack of seminal emission during orgasm. Again, this could be due to really poor diabetes control. The seminal vesicles that contain the ejaculate don't expel the fluid. Some men have had a history of testicular cancer, have undergone a lymph node dissection called an RPLND, where the nerves that control ejaculation are present, and if those are injured at the time of surgery, that can result in anejaculation. It can be after prostate cancer surgery where the seminal vesicles are removed and there's no further ejaculate, spinal cord injury. The treatment varies. Optimizing the testosterone could be a case. Penile vibratory stimulation can be a case for men with neurologic injury. I want to move over to male stress incontinence, and this will be the last topic we'll wrap up. And this plays a huge role for men who've had prostate cancer treatment. So stress incontinence happens when men put activity or pressure on the bladder, such as coughing, sneezing, laughing, standing up from a seated position, that can cause leakage of urine. Most common cause of stress incontinence is after prostate cancer surgery. Removal of the prostate can cause weakening of the normal external sphincter and pelvic muscles. And the majority of men will be continent after surgery after a year, but about 10% of men will not be continent, and we have treatment options for those men. This can also cause climacturia. So during arousal or intimacy with a partner, men could leak urine. That can cause sexual dysfunction as well. In terms of the treatment options, there's some behavioral changes such as using the restroom before intimacy or time voiding. Pelvic floor physical therapy, Kegel exercises after prostate cancer surgery is really the name of the game in terms of rebuilding that sphincter muscle. You can cope with it, right? This is not anything dangerous. It's just it causes significant impairment in men's quality of life from a sexual standpoint and from a daily activity quality of life with diapers, clamps, pads, and their surgery. So things such as male slings, as well as a prosthetic sphincter. Going into the male sling, this is really designed for mild incontinence in my book. It's an outpatient procedure where we place mesh that anchors to the bone and supports the urethra, helps restore normal bladder control. It's really not recommended. It's not effective in men with radiation. It's reserved for men with mild cases. Maybe they wear one pad or two pads or one or two diapers a day. A sling could be a good option for men. The gold standard is an artificial sphincter or a prosthetic sphincter. This has the highest satisfaction rates amongst men and can be used for any sort of incontinence. How it works, you can see here, it consists of three parts, kind of like the penile prosthesis. It's connected to a pump. There's a cuff, which is imagine a small blood pressure cuff around the urethra, connected to a pressurized balloon. And so the cuff is always closed, so you're not leaking after surgery. You squeeze the pump a few times. The cuff will relax and open, allow the flow of urine to occur. You'll empty your bladder, and then it will close automatically on its own, and you'll regain your continence. This is also typically an outpatient procedure, requires a few small incisions, a couple days to return to non-strenuous activity. Most men require 6 weeks after surgery before you can start using the device. So it's not immediate where you can start using the device. If men have had a history of radiation, we'll typically stretch that out to about 10 weeks. Again, we want to really give the chance for the urethra to heal after surgery before we start squeezing it closed with a prosthetic cuff. And the yellow here you can see is a photo of a real AUS device. The yellow means that it's coated with antibiotics that dissolves a week after the procedure to really minimize risk of infection. Risks of surgery, the device can stop working over time after 5-10 years. You can develop erosion of the urethra if the cuff is not properly placed or a cuff is too tight. You can go into urinary retention where the opposite effect occurs, infection, pain, soreness. Again, these risks are all pretty minimal, are pretty low. They're important risks nonetheless to understand. But this, in my practice, putting an AUS in a patient who's been leaking are some of the most happiest patients I've ever seen in my life. So it really works really well. Similarly, there's a website, fixincontinence.com. You can learn a little bit more about it. You can learn some from a patient standpoint and patient testimonials, how the AUS has played a role in their life. And with that, that's my last slide. I thank you so much for your time. Again, this is the contact number for my office here in Santa Clarita at Henry Mayo. This is my email. You feel free to email me if you have any questions or want to schedule an appointment, and I'll take any questions. And I think we have a few that I could read off here. Number 1, will testosterone treatment increase the size of my penis? I think that's a great question. The answer is no. It will not improve the size of your penis. Things that improve the length of the penis are penile stretching devices, the VED we talked about, getting a good erection and getting a penetrative quality erection, especially after prostate cancer surgery, will help maintain length of the penis and prevent atrophy. Does eating soy increase estrogen? I believe it does. I believe soy does can be converted to estrogen, but I think you need to be having a ton of soy for that to be effect. I mean, I have tofu and soy all the time. I think that's overall a main issue. And the important point with that is estrogen is important for men. You don't want your estrogen level to be zero. Estrogen plays a role in your bone health and also plays a role in libido. So I see many guys in my office on testosterone, on an aromatase inhibitor to turn off the estrogen, and their testosterone is excellent, right? It's 800, and they have no libido. It's because estrogen is negligible, it's non-existent. So you do need some estrogen. So I wouldn't be scared of having a little bit of estrogen on board. If you use these ED pills before you actually have ED, will it affect your ability to get an erection on your own in the future? No, I don't think so. I think these medicines just can help augment the blood flow going into the penis. I use it, all the time, even for young men who maybe have some anxiety during intimacy with a new partner. Guys want to achieve a pregnancy, and ED is very common amongst couples. And so I put men on a low dose Cialis daily for 3 months, 3 to 6 months, and at some point they stop taking it and have no issue whatsoever. Does prostate stimulation help with gaining an erection? Is it safe to do? No, I don't think so. I think prostate stimulation can help if it's vigorous enough, can expel some prostatic fluid or semen. I think it's safe to do. It's not very commonly done. It can cause prostatitis if it's done too frequently or too aggressively. So I wouldn't typically recommend it, but no, it doesn't help with an erection. Can you ejaculate with a penile prosthesis? Yeah, excellent question. So the implant does not affect the nerves of the penis. It does not affect your ability to orgasm. It does not affect your ejaculate. If you have an ejaculate before surgery, you'll have one after. If you don't have one before surgery because you had your prostate cancer surgery, you had your prostate removed, or you had a history of bad diabetes and now it's well controlled, and there's no further ejaculate, you have retrograde ejaculation or something of that sort, it's not going to change after an implant. So that, in other words, the implant doesn't change the role of your ejaculation. It's a really excellent common question. I think that's it. Well, great. Well, it was a pleasure to be with you all tonight. Again, I'm Dr. Kian Asanad. I'm a urologist here at Henry Mayo at USC. Feel free to meeting you all in the future. And if I could be of any assistance, please let me know. Thank you. Okay. Yeah. Oh, great. It sounds like we have a few more questions.
Sorry. Some questions.
Yeah. No problem. All right. Are you familiar with Resume and Urolift? Yeah, I do a lot of BPH work for men. I think those are excellent options for sexual sparing BPH procedures. I think both work well. I think it really depends on your prostate anatomy to see if you're a candidate for that. Yeah, would be happy to see you in the office. I offer both of them here at Henry Mayo. Are you familiar with how federal employee health plans will not pay for Cialis and Viagra? Yeah, the good news is Cialis and Viagra you can get for less than your insurance using a GoodRx coupon. There's a company called GoodRx, GoodRx.com, where you can type in Cialis, 90 tablets, and getting it at Costco is about $20 for a 3-month supply. I mean, it's not free, but I think it is much better than some of the co-pays, honestly. Nowadays, I have all my patients use GoodRx just because it's easier. There's no authorization required. Some of the authorizations only cover 10 tablets and not a daily tablet. So I think nowadays we can get 90 tablets of Cialis for about 20, 30 bucks. You can get a 10 milligram tablet, cut it in half. That'll last you 6 months. So I think it's really not much of an issue. And again, that's goodrx.com.
That's the second part of that question.
Okay. Will they pay for the mechanical treatments you offer? I believe so, yeah. I'm happy to see you in the office, and we can put a booking slip in and we can check your insurance and get all that squared away. It's no issue at all. But my impression for the surgeries for erectile dysfunction, yes. It's only things like Medicaid, some Medicaid plans such as LA Care may not cover the penile implant, in my experience. Excellent. All right. Well, thank you so much. Have a good rest of your evening.